by one of the new 7 wonders of the natural world, Table Mountain. And this same mountain overlooks another famous Cape Town landmark called Newlands Cricket Stadium. And interestingly enough, the first ever ODI, or one-day international, played at this venue was between South Africa and India in 1992, which I'm glad to say that South Africa went on to win by 6 wickets. I just thought that would be a nice way to make friends with my Indian audience. So just a bit of background. The focused assessed transthoracic echo, or FATE protocol, was developed by Eric Sloth and is well established and used widely around the world. It aims to help the clinician in making a diagnosis or to confirm a clinical suspicion as quickly and efficiently as possible, and to help guide effective treatment strategies. The first question I set on to answer was, is there any evidence that POCUS changes perioperative management? And the answer is yes. A study done in high-risk cardiac patients seen in a preoperative clinic showed that a POCUS scan changed the management of 54% of patients. And in 2 studies that scanned patients presenting for emergency surgery in a high-income country, there was a 43 and 44% change in perioperative management. An added benefit of performing FATE scans is the incidental finding of undiagnosed cardiopulmonary pathology. One study looking at emergency surgeries showed in 20% of cases, additional diagnoses were found. South Africa is classed as an upper middle income country and subsequently has a different patient population, which has public health challenges such as poverty, related illnesses, non-communicable diseases, HIV and related diseases, and a heavy burden of injury and violence. The majority of surgeries performed in South Africa are of an urgent nature, up to 66.4%, and this was shown by the SASOS study, which was published in 2015. So the hypothesis of our study was that performance of point-of-care cardiac and pulmonary ultrasound in patients presenting for emergency surgery in a resource-limited country results in a significant change in anesthetic management. It was a prospective observational study, and we calculated we needed to recruit a total of 62 patients to detect a 20% change in perioperative management. We included any consenting adult patients over the age of 18 that were coming for emergency surgery, and we excluded obstetric and elective cardiothoracic surgery patients. We scanned over a period of 2 weeks in September and October of this year between HOPAS 7 and HOPAS 4, and we excluded weekends. So our clinical methods, an anaesthetist, either a trainee or consultant, was sent to triage the patient in the ward or before anesthesia in the induction room, and they were then asked to complete a pre-FATE case report form. The FATE scan was then performed on the patient, and these findings were presented to that responsible anaesthetist. A post-FATE case report form was then filled in by the responsible anaesthetist, and we then compared the 2 forms to see if there was any change in perioperative management. Our primary endpoints were any change in perioperative management, as I mentioned, and these included things such as anesthetic technique, fluid management, any additional monitoring, and up or down referral, for instance, to say critical care or cardiology. Our secondary endpoint was to describe the prevalence of cardiac and pulmonary disease in our patient population. We are in a very fortunate position here at UCT to have adequate access to ultrasound devices that we can use on a daily basis, and we even obtained a loan of a portable Terrason 3100 machine for the use during our trial. To maintain validity of our results, we required scans to be done by a certified individual, and this did bring up some challenges because we had to balance clinical service delivery versus acquiring the scans. Although, as has been mentioned, FATE is very quick to do, and scans on average took between 5 to 10 minutes. There is a high turnover of cases in our emergency theatre, so this was another challenge that we had to deal with, and we limited our scanning to daytime hours just to prevent researcher fatigue. So just a quick run through of some of our findings. We performed a total of 67 scans over the 10 days. We had an equal spread of male and female participants with a mean age of 43. Over 50% of our sample group were ASA, American Society of Anesthesiologists Classification 3, suggesting on the whole, the patients presenting to our institution for emergency surgery have severe systemic disease. The comorbidities most frequently seen were hypertension, uncontrolled diabetes, and known HIV disease. And over 61% of the surgeries were booked with the triage designation of yellow, meaning that the case should be aimed to be done within 6 hours of being booked. On the whole, it was very easy to acquire good images during our scans, and it was only noted that in 8% of patients it was difficult to obtain good views. Interesting finding was that 32% of our patients were found to be hypovolemic before they came for surgery, and this diagnosis was based on left ventricular volume measured during systole with less than 3 centimeters used to suggest hypovolemia. This was then confirmed with inferior vena cava diameter measurement and presence or absence of IVC collapsibility. 92% of our patients were noted to have normal ejection fractions and MAPSs, and then we found 6 incidental pericardial effusions, the biggest one measuring 1 centimeter. Reassuringly, only 11 patients had abnormal valvular function, and this was with an equal spread between aortic, mitral, and tricuspid valves. And then 5 scans picked up pleural findings, all of which were pleural effusions or hemothoraces. So I just thought I'd highlight 4 scans where we thought that fate had an influence on perioperative management. So this first scan is from a 27-year-old ASA3 patient, female patient who was booked for uterine evacuation under general anesthesia for query molar pregnancy. She presented with PV bleeding and had a positive pregnancy test. Clinically, the patient was not hypovolemic. The blood pressure was within normal limits and the pulse was 91. She was anemic with an HB of 8.8 and biochemically hyperthyroid. She had been medically managed with neomercazole, Lugol's iodine, and a beta blocker preoperatively, which was then stopped. Our FATE findings showed that the patient was hypovolemic with normal ventricular function, and a pre-induction fluid bolus was then given, as well as blood being ordered to be in theatre. The second scan is of a 32-year-old male patient who was booked for a transesophageal echo plus minus subxiphoid window under general anesthesia. He had a history of 1 isolated precordial stab wound and was referred from a peripheral hospital in a stable condition after an EFAST scan, so an extended focused assessment with sonography for trauma scan, showed a 1 centimeter pericardial effusion. Our FATE scan showed that the patient was euvolemic, that there was good left ventricular function, and that a 0.5 centimeter pericardial effusion was present, which was not causing any right ventricular collapse. Lung ultrasound showed no abnormalities, which was reassuring, and the findings were relayed to the trauma surgeons who decided to continue with the procedure as they had booked. The next scan is of a 34-year-old ASA3 patient who was booked for exploratory laparotomy for a query ectopic pregnancy. The patient gave a history of having 2 previous DVTs and a pulmonary embolus and was previously on warfarin but defaulted her treatment 4 months ago. Clinically, there were no symptoms or signs of a current DVT or pulmonary embolus, but however, the patient had had no further workup done before coming to theatre. Our FATE scan was reassuringly normal and showed no features of right heart enlargement, and the right ventricular function was good, with the TAPSE or tricuspid annular plane systolic excursion of 20 millimeters. Considering the normal scan and the urgent nature of the procedure, the surgery went ahead after discussion with the surgical team. The last scan I'd like to talk about is of a 34-year-old gentleman who was previously well, booked for a left-sided thoracotomy for clear out of a retained hemothorax. The patient had an intercostal drain in situ on the left-hand side, which was not draining any blood anymore, and there was no ICD on the right-hand side. The chest X-ray showed bilateral blunting of the costophrenic angles. Our FATE scan showed a normal functioning heart. However, there was an incidental finding of a 9 millimeter pericardial effusion. Pleural scanning showed a consolidated organized hemothorax on the left-hand side, but on the right-hand side, you can see in that scan, there was an approximately 470 ml hemothorax visualized. This information was then relayed to the surgical team, and the decision was made to proceed with the surgery. However, a right-sided intercostal drain was then inserted post-induction. So Unfortunately, I can't comment on the primary outcome of our study because we haven't been able to analyze the data fully yet. But what we can take away from doing the study is that performing POCUS in the perioperative setting is feasible in a resource-constrained environment, and that it provides useful information that may influence perioperative management. It can also minimize delay in patient management in whom they would traditionally and have to have waited for formal echocardiography from cardiology. And just those are the references in case anyone would like to have a look at them. Thanks very much.
Thank you very much, Robbie. So the whole point is that you scan these patients, and often they have been starved for a while and they are hypovolemic.
Yeah.
And almost all of our urgent cases or patients coming to theatre, they're all hypovolemic. And remember that we try to be conservative with fluid, but often that is what they need to, that would be a good message. Thank you very much. So next, it gives me great pleasure that we can just get the camera on our next speaker is Dr. Matthew Gibbs, who's one of our senior colleagues, who is the leader, director of our transthoracic training program. And with him is Dr. Elmar Krieger, who is one of our registrars, and we have convinced him that he must show his chest so that we can scan it. So thank you, Elmar, for that. We're going to try and just maybe on Dr. Gibbs' face, Matt Gibbs' face to start, and he's going to say a few words before he's going to talk to us about the scanning. Thank you, Matt.
Okay.
I'll leave you there.
Thanks for the introduction, Prof. Hi, everyone. It's wonderful that we can use technology in what's normally very much a hands-on session. Most of our training is in terms of teaching point-of-care echocardiography. It's always one thing to talk about it, it's another to actually practically perform it and actually put your hands on the probe. So this is certainly a different experience, trying to teach echocardiography across 6,000 kilometers. But I hope the combination of the views of the ultrasound machine and how I'm holding the probe will be very enlightening and informative, and that you will hopefully encourage you to learn and to apply these skills in your perioperative practice. It's certainly one of the biggest changes to my perioperative practice in the last 10 years, and I hope you will see the benefit. So Elmar has kindly volunteered at the point of an echo probe to be my victim, my patient. So I was going to go through a very simple scan. When we do point-of-care echo training, we intimidate our colleagues by saying that the day, which is normally a one-day course that we offer, that by the end of it you should be able to acquire a decent scan, a full echocardiography, or at least a simple point-of-care scan within 2 minutes of beginning your scan. And it sounds very scary, but it's actually very doable once you learn the basics of the procedure. So we're going to start with which is position 1 on your FATE card. You can actually download the FATE card off the internet in PDF or usabcd.org. It's all freely available. And we're going to start with the subcostal 4-chamber view. So just a reminder that if we are able to zoom in on the probe, with a traditional phased array probe, it is a low frequency probe, remembering that low frequency penetrates deeper. High frequency probes are used, linear probes are generally used for vascular access, and they only penetrate to a maximum of 6 centimeters, so depending on the probe. With a phased array, you can penetrate deeper to 20, 25 centimeters. I'll talk to you as I go explaining the use of all these complex knobs that you see on the machine behind me. So let's find our anatomy. So just below the xiphoid sternum, there's a space. There is an orientation marker on the side of the probe here. And that orientation marker, in pretty much all the most basic views, points towards the patient's left-hand side. So you need to make sure that it is pointing correctly. So putting on my probe, I start seeing a beating thingy. And it's always good to see a beating thingy in a patient. You can encourage them that they are actually alive. I am busy changing the depths on my machine. Each machine, each manufacturer has a certain way of setting up their machine that's a little confusing as you move between machines. So get used to the machine that you have in your own individual practice, so that it becomes easier and slicker as you more you use it. So I'm using my probe to always have a 3D picture in your mind of where the heart is in the chest. Now you've got the apex on the left-hand side of the chest, and your base of your heart is beneath your sternum, and it's lying across the chest. So if you don't aim your probe towards where the heart is, you're not going to see it. So one of the most common problems I see is the probe gets placed directly on the patient's abdomen here, and as we know that the heart is not an abdominal organ, it is more useful to lower the tail. If you notice there, I'm lowering the tail of my probe, looking up to where I expect the heart to see. And now on my screen behind me, I can see the 4 chambers of Elmar's heart. Elmar, can you take a nice deep breath in for me and hold? And you can see that with that deep breath, my image has improved. I changed my depth so that I can see the entirety of the heart. And using my pointer, I should be able to show you on the screen. There's the left ventricle, right atrium, and left atrium with your mitral valve and the tricuspid valve. You can breathe normally. Thank you, Elmar. So this view is a useful view to observe global ventricular function, gross abnormalities in filling, tamponade, large pericardial effusions. It's maybe the only view that you can see in a patient with COPD. Often patients are hyperinflated. It's very difficult to see the rest of use the other views as traditional parasternal views because of the hyperinflation. And in fact, with the movement down of the heart due to this hyperinflation, you actually get a really good view from the subxiphy. And we can modify our views such that we can examine for ventricular function in the short axis as well. So this is usually your starting view. In patients that are obese or pregnant, it obviously becomes a lot more difficult. Patients with surgical wounds, who have a laparotomy, this obviously becomes more difficult. From this view, what we often like to look at is the inferior vena cava, and it's relatively easy to have a look at. From this position, I rotate the probe 90 degrees so that the orientation marker that I'm pointing to here points directly up towards the ceiling. At that point, I can see on my screen, you can see the liver on the left-hand side. I lift up my tail of the probe, looking back, you see a pulsation of a vessel, a dark black thing there. There must be fluid floating there. The more I move to the left-hand side, the patient's right-hand side, I see another vessel. So I'm going to, what do you call panning the probe? We look back across, I see the aorta, and the patient's more to the patient's right-hand side, see a nice full inferior vena cava. Take a nice deep breath in, Elmar, and breathe all the way out. You can see the variations in intrathoracic pressure results in a change in your preload, which results in an increase and decrease in size in your inferior vena cava. And this is one of the views where you would look at IVC variability. We also know that this is IVC because you can clearly see liver above and below, whereas in the aorta, there is no liver below the aorta. So I'm going to go back to IVC, and you can actually follow your IVC directly into the right. If I look up, I can see it going into the right atrium, right over there. So I know that this must be the inferior vena cava. So moving on from our first position, just a reminder, you can never have enough jelly. I'm going to move to our apical four-chamber view. So remembering, usually I ask the patient to do a feel for the apex. Place the probe such that the orientation marker is pointing again into the patient's left-hand side, to the left axilla. But now I'm orientating it so that my probe is aiming towards the patient's right shoulder. So I'm expecting to look straight up the interventricular septum up towards the base of the heart, so we get again a global picture. I'm not getting great views at the moment, so usually it involves a little bit of moving around, and now you can see all four chambers of the heart. So this is an apical four-chamber view. So here's an interventricular septum in the middle of the screen. We're trying to keep it as in the middle of the screen as possible. The left ventricle, the right ventricle, right atrium, and the left atrium, with the mitral valve and the tricuspid valves both pointing directly back towards my probe. So this is one of our favorite views, gives us a lot of information, and when we start doing valve evaluation, this is one of the views we use most often, because the flow of the blood is going directly towards the probe. And if you look at, you remember your Doppler equation, you want to be as parallel to the flow as possible so that you're able to pick up a Doppler shift if you are doing measurements. So this will give us, as you change the angle of your probe, you're going to see different structures. This, I'm holding a probe so that I'm aiming at a more posterior structure. This is a coronary sinus appearing on the screen now. As I lower the back end of my probe and I'm starting to look up, I become a more four-chamber, and the further I look, I start seeing a five-chamber view. And you can see the aortic valve appearing in the middle of the screen there. You can see it next to my arrow with the aortic valve opening and closing. So when we try not to use too many advanced modalities when you're teaching basic point-of-care ultrasound. So I'm going to go through the full exam, and we'll go back to application of some of the other modes, M mode and Doppler. Doppler we try to reserve for more advanced views, but M mode is a useful modality that gives you a lot of information when you are examining and learning. So we're going to move to the parasternal views, which in my book is probably your money shot views that give you the most information in many circumstances. So I'm going to cheat because I really know that my views are going to be improved by this. But when you are struggling to get a good parasternal view, as well as your apical four-chamber, the best thing to do is to ask the patient to turn on the left-hand side. So, Elma, can you do that for me, please? I normally sit right next to the patient. Obviously, in the time of Corona, we would consider using more barrier protection, depending on what sort of exposure you have to COVID-19. So the parasternal views, I'm going to start usually the second or third intercostal space. This is the parasternal long axis view. And if you look at my probe, my orientation marker is pointing directly towards the patient's right shoulder. And you place the probe perpendicularly on the chest. So Elma's got a very nice view. I'm going to adjust my depth of my screen. The reason why I'm going to show you some of the artifacts that you can create by not paying attention to some of the basics of echocardiography. So in this view, we've got a good view of the left atrium over here, mitral valve opening and closing, left ventricle, the left ventricular outflow tract, aortic valve opening and closing, and Yes, that's my point. Okay. The ascending aorta. But if you look at this, this image, it looks like I almost got two hearts. This is called a ghost image. And this is the result of not optimizing your view. So what's happened is that you've got a very strong reflector in your pericardium. And there sets up a reverberation signal between that pericardium and the transducer itself. And the transducer detects the extra reverberations as being twice the distance of what it actually comes from. So you can see that you create a second heart at a depth below that pericardium. And to improve that, I'm going to change my depth. There's a number of benefits to this. You remove that ghost image, plus your frame rate improves and allows you to have a better image and greater clarity of detail when you're examining this patient. So peristernal long axis views gives you a lot of information about movement of the aortic and mitral valves. We're able to work out fractional shortening from this image. We're looking at how well the left ventricle contracts towards each other, as well as the relative size of the left atrium and the left ventricular outflow tract and ascending aorta. And generally speaking, you expect that to be around about the same size. And if you see a ratio of 2:1 with the left atrium, twice the size of the aorta, you can safely say that you have a dilated left atrium. A peristernal short axis view involves a rotation of the probe 90 degrees from that initial view. So I'm going to go back to my peristernal long axis. Orientation marker pointing to the patient's right shoulder. I rotate 90 degrees such that the probe is, the orientation marks pointing directly to the left shoulder. And you see that I've rotated on the mitral valve, and right in the middle of my picture is the mitral valve opening and closing in the middle of the picture, and I'm cutting through the left ventricle in a short axis. If I move my tail of my probe a little bit towards the right shoulder, I get a mid-papillary short axis view, which is a very useful view in terms of measuring, looking for regional wall motion abnormalities, evaluating for pericardial effusions, and the relative size of the right ventricle with the left ventricle. So we're going to see that here on the top left-hand side, you've got the right ventricle, you've got your interventricular septum in the middle, you've got papillary muscles, and you see that if you put your probe in the middle there, that's all areas of the heart are moving equally towards the middle. So there's no sign of regional wall motion abnormalities. There is good function, good movement, and we can safely say that we have a normal examination. There are further and more advanced views that you can use from this position, all involving just moving the tail of the probe further down, which allows us to evaluate the mitral valve in short axis. The more I move, I'll eventually get onto the aortic valve in short axis. You can see a tri-leaflet aortic valve appearing in the middle of the picture, as well as evaluating the tricuspid valve, pulmonary outflow tract in the left atrium. But these are the more advanced views, which you not necessarily require for more basic point-of-care ultrasound. So those are the four basic views. So subcostal four-chamber, apical four-chamber, peristernal long axis, and peristernal short axis. All right. So I'm now going to move towards, I'm going to always include pleura. The fate protocol always is always, the idea is to always evaluate the pleura. So to evaluate for lung the pleura, patient normally lies supine. Orientation marker always points cephalically up to the patient's shoulder, usually posterior axillary line, and we're going to look for the, that's better. I'm going to change my depth here again. So it's now a little bit too shallow. I'm not seeing what I'm needing to see. There we go. Okay, all right. So here we've got the spleen in the middle of the picture. On the right-hand side, we see the bright white dome of the diaphragm, and above that is where we expect to see any pleural effusion. If there are other abnormalities like a pneumothorax, you would struggle to see any object whatsoever, because air is such a poor transmitter of ultrasound that most of the image gets transmitted, gets lost completely, and you're not able to see anything. So looking on the other side of the patient, again, orientation marker is cephalic. And I'm going to look at the patient's right-hand side, again, posterior axillary line. And we can see a little bit of almost spine at the back here. This is his liver, and with his breathing, you can see the diaphragm moving up and down. And if you develop a large pleural effusion, what you'll see is that you get a large black pool of inky fluid. As demonstrated, Robbie showed a very nice video of a large hemothorax, and you can see that you develop atelectasis, and you normally see the tip of the lung sort of floating, flapping around in the breeze, so to speak. So when you're doing evaluations, always remember to look at the pleura. Just to briefly mention lung ultrasound. In the days as we are dealing with corona more and more, lung ultrasound has certain benefits when dealing with the acutely short of breath, and can help you detect major pathology such as pneumothorax, which is quite common in patients with COVID. You're able to pick up fibrosis as well as your pleural effusions. So I'm going to quickly show you one more, slightly more advanced view that Swanevelder demonstrated, and that was the suprasternal view. And the patient with chest pain, this may be useful in looking for presence of a dissection, of aortic dissection. So in this view, it can be a little bit uncomfortable for the patient. You normally ask the patient just to lift their chin a little bit. Sometimes you may need to put a towel behind the back just to extend the neck a little bit. Orientation marker aims posteriorly, goes directly towards the patient's back, and you look for the aortic arch, a little bit of manipulation. So you can see here we've got the aortic arch coming up and over. I'll put on color just to demonstrate the flow of blood going down the descending aorta. So there's our descending aorta with the left subclavian coming off over here. It's difficult to see the head vessels.
Your scale, if you turn your color scale down, maybe decrease the depth of your...
Yeah, we can decrease the depth a little bit.
And maybe you see this frame rate.
And there we can see a little bit more of the left subclavian there. Okay. But sometimes you may see the dissection flap, and if you are doing more advanced surgery like a TVAR, thoracic EVAR, you can actually see the introduction of the wire from below. Okay. What other views would you like to, shall we demonstrate?
I've got a few examples. If you
I was going to quickly, let's go back to the apical forechamber. I was going to demonstrate where M mode may be of benefit. So, Alma, can you turn onto your left-hand side again? Go. Great. So I'm going to go back to our apical forechamber. And just, again, getting your depth correct is of uttermost importance. It's a pretty useless view here. You cannot see your left atrium or your right atrium. I'm going to change my depth until I get an optimized view. Okay. So M mode is your motion mode. This gives you one of the most high definition temporal views of the heart. And M mode involves one set of crystals continuously firing at all times, and it gets mapped against a time scale. I'm going to freeze this here. So what I've done is that I have now got a epical 4 chamber. The M mode cursor goes through the lateral annulus of the mitral valve, and the more it moves towards the apex, the more the mitral valve annulus moves towards the apex of the heart, the better the ventricular function. So in this particular case, we've got a mitral annular plane systolic excursion of 1.68 centimeters. So it's more than 1.2 centimeters, implies good left ventricular function. Just remember that you are not an echocardiographer, but we are able to evaluate some basics that will allow us to exclude grossly abnormal ventricular function. And this is a reassuring finding in conjunction with other evaluations of ventricular, including ejection fraction and fractional shortening, that allow us to say that a patient has got a normal ventricular function. If I go to the same view and I put my M mode on the patient's right-hand side, I get, again, a similar equation, the TAPSE, or tricuspid annular plane systolic excursion, and you do a similar measurement and you expect it to be more than 16 millimeters. And in this case, it's well more than that. In fact, it's 2.3 centimeters. Again, not reassuringly normal. And there's been clear demonstration that abnormal TAPSE in patients with pulmonary embolus is associated with increased mortality. So it's a very useful measurement to take. This is a useful and easy tool in a point of care ultrasonographer's armory. So the last demonstration of M mode is going to be in your parasternal views. Once again, I'm going to change my depth. I'm going to optimize my view. And you're placing M mode through the middle of your ventricle. Got some very nice clear images there. Take a nice deep breath in and breathe all the way out. So on expiration, we have our best possible view. There we go, thank you. I'll make him breathe normally again. So now on expiration, we've got our best view. So you can see the size of the ventricle in diastole, and you can see the excellent thickening of the ventricular wall in systole. And we can subsequently work out a fractional shortening and an ejection fraction using the software that's on your machine. I'm not going to go through all of that now. That can be done at another stage. I'm happy to take any questions. Prof, do you want to demonstrate? Thanks, Omar.
Okay, are there at this stage any questions? If we have questions, then maybe, otherwise I will show a few more examples. If there are questions from the audience, and I'm sure the organizers on the other side would have collected them. Otherwise, we've got a few examples of interesting cases that will keep us going for the next 15-20 minutes until the session is over, I think. Or is the time up already from your point of view? Is the time up?
So you can continue, sir, with any extra slides that you would have, sir.
We'll take the questions at the end if that's okay with you.
Okay, let's go for that. I'll go down to there. Just give me 1 minute to get to the right spot. Okay. So thank you very much, Matt and Elmar and Robbie, and I hope that sort of could add to the, to the explanation why this is so valuable to our practice. I'm going to look at a few cases of hemodynamic instability, and Matt has talked about the Table Mountain, and I can tell you the Newlands cricket pitch is on the other side of the mountain on the left. Are we on there? We're on, okay. So the cricket pitch, Newlands, is on the other side of that mountain, very close to our hospital, and I can tell you on the 1st, 2nd, 3rd, and 4th of January, there's always an excellent international there, and with India's interest in cricket, we often see their team play there, so really nice to be so close. I'm going to start with this 33-year-old obstetric patient, and the patient has got hemodynamic instability. Now the trick here is that this happened about almost 2,000 kilometers from here. So this, I would say, is the ultimate of telemedicine. Not everywhere in South Africa they've got people with a lot of expertise, but most places, or many places, will have ultrasound machines available, and everywhere there are keen people who are learning. So this came from Pietermaritzburg when a colleague phoned me and said they've got this primigravida, 24 weeks gestation. And the patient has got HIV positive on retroviral treatment, acute dyspnea and hypoxia with severe preeclampsia, and now developing HELP syndrome. So the question is this peripartum cardiomyopathy, or is it just a preeclampsia, or is it a combination? And the attempted induction of labor failed. So now you sit with this patient with a sort of non-viable fetus, and the patient is in trouble. And the person on the other side, the obstetric anesthetist, did one of our courses and was good to get an echo image on the screen, and then took a picture of this, send it via WhatsApp to me, and ask, what shall I do? Now, I'm not a big obstetric anesthetist myself, so I immediately asked my experienced colleagues, Professor Rob Dyer and Dominique van Dijk, and say, what shall we do? And we looked at this picture and thought, this is not it's not a perfect apical 4-chamber, but you can make a picture and recognize the structure. So immediately I could say the mitral valve is not affected, the tricuspid valve looks all right, but the left ventricle has got hypertrophic or concentric hypertrophy and really looks impaired. So either the afterload is hugely increased, or the patient's now got some sort of peripartum cardiomyopathy, which is a bit early in this pathology. We say, well, turn it a little bit, rotate it clockwise, and that was an apical 4-chamber. Now we're going to a parasternal short axis view, and this is what we see, and it's certainly a struggling ventricle, and the patient is now in big trouble. And then again, a parasternal long axis view, and I was looking very carefully at the aortic valve there and the ascending aorta. I was wondering, can that maybe be a dissection, which we know is common in the obstetric, or one of the common causes of obstetric hemodynamic instability, but it eventually turned out not to be. The patient's left atrium is not too big, the mitral valve opens, but there's certainly a very short ejection time, so there must be a very high afterload. So after a long discussion, the decision was made to do a hysterotomy under general anesthetic to stabilize the patient and to transfer to a tertiary referral hospital where they could then, which was about 150 kilometers away, where they could have strong cardiology support, and they could make a diagnosis then of hypertensive cardiomyopathy. In other words, in our setting, preeclampsia is still very much commonplace. We see it a lot, and even eclampsia where patients undergo, fit, have seizures, but the patient was then treated accordingly and doing well. So that's a nice example, and since then we've done studies. Elmarie Neethling, Professor Dyer was driving this, Elmarie Neetling was helping, and Clemens Ortner, Vijay Krishnamurti from Stanford in the States. They spent some time with us and we came up with this very nice publication in anesthesia and analgesia of point-of-care ultrasound in the obstetric patient and how it correlates with other biomarkers. I'm not going to go into the detail of the study. This is a 24-year-old patient, Gravida 1, Para 1, and 36 weeks gestation for a cesarean section. And this is now a transesophageal echo picture. See whether you can recognize some of the structures. We've got a huge left atrium closest to your transducer, which is in the esophagus. There's a mitral valve, which is restricted in its function and opening, smallish left ventricle, dilated and hypertrophic right ventricle, and just under the color box here we can imagine that there's some tricuspid regurgitation with the interatrial septum bulging across to the right side. In other words, a very high pressure with spontaneous contrast. So this can really not be much other than mitral stenosis, which again is pathology we see, rheumatic heart disease in our country a lot. Patients come in from rural areas at a late stage and then comes into pulmonary with a pulmonary failure, pulmonary edema and cardiac failure. This case, the gradient, mean gradient under anesthesia was 8.3 and the maximum gradient 13. Now remember, we offload the heart when we go from spontaneous ventilation to anesthesia and positive pressure ventilation. And just there on the right side is a very, very tight mitral valve area and opening. If you use the pressure half time to 20 over pressure half time is 2 to 5, and in other words the mitral valve area is less than 1 square centimeter. So again, look at the tricuspid valve, tricuspid regurgitation severe, the left atrium very much like a football with a septum bulging across, and this patient is in big trouble with if we use the Bernoulli equation, we say 4V squared plus the CVP. If we take the peak of our tricuspid regurgitation, it means that we've got a systolic pulmonary artery pressure of almost 70 millimeters mercury. This is huge, and this patient is in big trouble. Now, we just move on. Let me just see what else we've got here. Yeah, I'm going to stop there and ask whether we've got any questions. I think that's our transthoracic images and examples. So I'm going to stop sharing my screen now, and if there are questions, there's another 10 or 8 minutes left before the end of the session. So any questions from the audience?
Yes, so we have a few questions. The first question is by Dr. Avinash. Which method is more reliable?
Yes.
Sir, I'll begin again. Which method is more reliable for the assessment of hypovolemia, the IVC diameter or the left ventricular volume?
Is it possible to use focus?
Yes, we can go back on the picture on this. If you can, can you go on our screen?
Yes, sir, you can share your screen, sir, if you wish to.
We will share our screen.
Do you want the slide? No, we didn't know.
Not slides, just sharing. Yeah, video. Okay.
Do you want to see that?
Yeah. So come and sit next to me. If Robbie can come around and come and sit. Maybe if we move Elmar, you are obsolete now. Get out of the way, Elmar. We just rearrange our setup here, and then we'll. So, Robbie, can you squeeze in there? So, yeah. Thank you very much. So I would say, you know, if you want a quantitative number, then the IVC can give you a number. If you look at the left ventricle area or you look at volume, remember that the volume in 3D, we're looking at a two-dimensional picture. If we talk about a volume, then we have to calculate a 3D volume. Even with 3D ultrasound, we are calculating a volume or putting a data set together to come up with a volume. So with ultrasound, we are very good at eyeballing and pathology. We are very good with qualitative assessment of a picture. So we recognize a picture. Is the heart empty or is it full? To come up with a number is a little bit more difficult and less reliable because a number depends on so many factors. The question is, what is the afterload? What is the preload? What is the situation that you're in, the context? Is it an anesthetic a patient under anesthesia, or is it an awake patient? So is the patient, you know, on a trauma patient, maybe a high adrenergic drive, you know, sympathetic drive at the same time. So all of those we have to keep it into context. So I would say it is fairly easy to look at the heart and say it's empty or it's full. The in-between is more difficult. The moderate impairment, the moderate filling or moderate hypovolemia is more difficult than to say it is severely hypovolemic or it's overfilled. You want to add to that?
So just make just a couple of comments. In terms of IVC variability has been demonstrated to be of benefit in volume assessment. Just remember that the IVC is part of the venous system, and the venous system has got a tremendous capacitance. And can take a lot of volume. It can, until it's actually stressed such that you have an overloaded IVC, you won't say that it's that you've got too much volume. So generally speaking, if you look at the IVC, the view I demonstrated just now, generally speaking, you'd expect it to be 2 centimeters or less. With some degree of collapsibility, more than 50%. If it's an IVC is more than 2 centimeters and there's no respiratory variation, there's no collapsibility, you can probably, really distended tight IVC, you can probably safely say you got a CVP around about 15 or so. If on the other hand, it is completely collapsing throughout the respiratory cycle and the patient is tachycardic, and you've got a small volume ventricle, you can probably very safely say this patient is hypovolemic. Always remember that you're not just looking at one particular view, you're not choosing just one measurement on which you're going to base your assessment. You remember you're a clinician first and foremost. You look at your patient as a whole, you apply your various examinations, you can use your stethoscope, although I believe the ultrasounds are stethoscope of the 21st century, and you look answer the question that you're asking, is this patient hypovolemic or not? And you'll look at your IVC variability, you'll look at your end diastolic volume, you'll look at the other measurements that will give you a clue that the patient is hypovolemic, and you put that all together when you're assessing the patient.
Yeah, I would add exactly what you say. It's all the context. If a young patient with a previously normal heart history comes in and they're hemodynamically unstable and they've just been in a car accident and you see the blood flowing, then you don't need an IVC number or measurement to put it into context. It may be different when it's a controlled situation. And remember the sniff. When you ask a patient to sniff, a patient who's awake, and you ask them to sniff, and the IVC collapses. Yeah, so I think one must just, it's part of your ultrasound investigation, and I would first look at the ventricle, then take the IVC. And that's really to say, is the CVP less than 10 or more than 10.
Yeah.
You know, you can, it's been validated and correlated with the central venous pressure. So especially in the critical care setting, they use the IVC measurements a lot. If it's controlled or in a trauma setting, maybe not that much.
It's easy to manipulate with inotropes and with vasopressors, whether the patient's intubated and ventilated or not. Those are all going to affect your preload and how you're filling.
Any other questions? If that answers the question, any other questions?
Yes, sir. Thank you very much. We have a few more questions here. Dr. Janish Kamat wants to know what is the role of transthoracic echocardiography in the intraoperative setting?
That's interesting. You say, Matt?
Okay, what I've found is that it's just a matter of having the courage to apply the probe. So a patient, the number of times in obstetrics where it is possible to monitor the patient's heart throughout using a standard transthoracic approach, your parasternal short or long axis. In pregnancy, there are certain advantages, in fact, when you do transthoracic echo, because of the changes in pregnancy, the elevated diaphragm is pushed up, the ventricle gets moved closer to the left-hand side of the chest, and the patient obviously is normally put placed with a wedge underneath the right hip, which allows the heart to become even closer to the chest wall, and becomes quite easy to assess the heart. So throughout a patient under spinal, even under general anesthetic, you can apply a transthoracic probe. However, in certain cases, thoracics, cardiacs, a transesophageal echo is going to give you a lot more information. It's going to be impossible if your surgeon is working on that particular area. But it's only thing that's limiting you is whether you can find a place to put your probe. Some patients are easy to echo, some patients are not easy to echo. And if you're struggling with a transthoracic echo, is there a contraindication to transesophageal echo? Do I have the expertise? Is there someone I can call to give me assistance? Do I need to apply some other cardiac output monitor?
So, for instance, in hip and knee replacements, people have studied the embolization, air embolization, and also the cement embolization syndrome during the implantation of the cemented hips, and then used transthoracic transducers. Transesophageal, I've been involved and used transesophageal echo in those settings, but not published on that. But people are, most of the publications in the orthopedic setting would be transthoracic. I concur with Matt about the obstetric setting. We've had a few practice runs here to see, and you know, patients around the cesarean time and fluid and changes, and we're busy setting up a study like that. There was one more thing that you mentioned that they were. The question was about
transthoracic echo intraoperative.
Intraoperatively. Yeah, I think that's more or less. It's less because of the you know, where the surgeons stand. Most of the time you don't have that much access. Oh, I remember now. What I wanted to say is that one of the vendors, I think it's Sonosite, has got basically a holder, a brace, which you can put on the chest so that you don't have to be there, that you can fix the probe on the patient's chest. And maybe that's something to revisit. I think a year or two ago they came out with this, and where you don't have to hold the probe, but you get a good view and you fix it on the chest and then clean and drape the patient. So that would be good.
One last comment is that the transthoracic, often, remember, transesophageal echo is often less available. The machines may be used exclusively in the cardiac theatre, less available.
Probe is expensive.
Probe is expensive, and in certain cases you're not able to use it. Transthoracic is easily available, and in patients that with sudden changes intraoperatively, we have a cardiac arrest due to argon gas embolism, cardiac arrest due to local anesthetic toxicity, cardiac arrest due to thrombus propagation, and thoracic echoes allowed us to guide therapy, guide resuscitation, look for problems during the resuscitation intraoperatively. It's also allowed us to help assist with diagnosis. And in some cases where we cannot understand why a patient is hypotensive, when we've applied our usual cardiac output monitors and our systolic pressure variation, our stroke volume variation, it all appears normal. A transthoracic probe allows us to have a look and say, oh, this patient is actually completely hypovolemic, and giving volume reverses the amount of inotrope that we're giving to the patient.
More questions?
Thank you, sir. You brought out some really valid points there. Next question is by Dr. Anita Nileshwar. She wants to know if a patient under general anesthesia develops sudden severe hypotension, how would one want to use point of care ultrasound? And is there an algorithm to rule out the causes?
You say hypotension.
Sudden hypotension.
Sudden hypotension during...
Logically, remember your clinician first. You're going to evaluate your patient, look for signs of bleeding, think logically what is the most likely cause. If you've got a patient who's in a seated position, for example, and they're doing basic skull surgery, you're going to think of an air embolism first and foremost, and that's going to be the most likely cause of your hypotension. You look at your carbon, your CO2 outputs and see whether that's something like that has happened.
What you say, Matt, is absolutely true. This is an extension of our clinical practice.
Exactly.
Now, if you ask specifically about ultrasound, then it is, like I said earlier, it's easy to see, is the heart empty or is it overfilled? Yes or no? Is the heart contracting or is it failing? Yes or no? Is there effusion around the heart? Very easy to spot, to see. Yes or no? A little bit more difficult is a wall motion abnormality where you say, well, this is ischemia. No, usually it's any of the others before it becomes real ischemia, but it can be. So yes or no, and that's when the heart, is there dyskinetic segments? So is it instead of during systole moving out instead of in? And is it not thickening and staying thin? So that's usually the type of way I will use ultrasound itself. But of course you have to exclude all the other. And yes, just to the previous question, good afternoon to Dr. Kamat, who I've seen long time ago, who asked that question. So it wasn't like we set it up, the question. Dr. Kamat, nice to hear from you. Any more questions?
Yes, sir. We have a couple more questions with us. Dr. Anil Kumar wants to know, how can we rule out pulmonary embolism with transthoracic echocardiography?
I think, Matt,
yeah,
that's an easy one, Matt. Come on.
You can't exclude pulmonary embolism with a transthoracic echo, but you can see hemodynamically significant pulmonary embolism. We're looking for signs of acute right ventricular overload. We're looking for a shift in the interventricular septum. I demonstrated the parasternal short axis, where you can see the right ventricle and the left ventricle in short axis. And as you get an increase in right ventricular pressure, the interventricular septum gets moved across. You start getting what we call a D-shaped left ventricle. And that's in a patient who previously had a normal left ventricle. You develop an acute increase in right ventricular pressure. Remember, the right ventricle doesn't take pressure very well and starts affecting the left ventricle. And you start seeing those signs and you are very concerned about pulmonary embolus. You may see other signs. It is possible to look for a saddle embolus in certain views. But that takes certain skill. The lack of, if you're unable to see a clot, doesn't mean that the clot is not there. So you look for signs of acute pulmonary hypertension rather than the pulmonary embolus in and of itself.
I think to add to that is microemboli is one thing and you may not see it.
Yep.
But a huge embolus coming from a DVT, you may see in the inferior vena cava drifting around. You may see, if you've seen a thrombus once, you'll recognize it anytime because it may be in the right atrium, it may be migrating through the right ventricle into the pulmonary artery. Sometimes very difficult if it breaks up and it breaks into the pulmonary arteries on the left and right side. But Matt has explained very nicely the reverse Bernheim effect, where everything is pushed across to the left. The right ventricle does not like an acute increase in afterload. It can deal with volume very easily, but not an acute increase in afterload. And so that would be my story to add to what Matt said. A big right ventricle, big right atrium, and a patient who is crashing.
Yeah.
One last query, sir. Not relating to the subject per se, but we've heard so much about TTE today. We are eager to know, are there any online or e-courses to learn echocardiography, sir?
On your side.
Online tools.
Online tools. Yes, so we, so many. Matt, Eric's thing is a fantastic.
So there's two I can recommend, usabcd.org, which is set up by Eric Sloth. He's got an extensive e-learning package, which is available.
Just say that again.
usabcd.org. Then we can share the links at another stage. And then David Canty, Colin and Alistair Royce have set up excellent focused ultrasound training from the University of Melbourne. I can't remember the exact address.
Heart scan.
iHeartScan.org. Two excellent online platforms. Just remember that the e-learning is, of course, essential, gives you the basics, goes through the physics as well as the basic views. But in terms of the actual practical application of ultrasound to the chest, it's always best to have someone just to guide your hand. And there are a number of courses set up all around the world. I was in Chennai as part of the Ramachandra Anesthesia Continuing Education 2019. We did workshops over 3 days, 1,200 delegates, and it was a great opportunity for delegates to put their hand on the probe and to actually see what they could see in the patient's chest.
Thank you very much.
Thank you, sir. This brings us to the end of our question and answer session. We'd like to thank Dr. Swanevelder and his entire team for this very informative talk. And we hope that we've managed to convey the importance of the transthoracic echocardiography and our role as perioperative physicians. Thank you, sir, for graciously answering the questions. And as a token of our appreciation and gratitude, please accept this e-certificate.
Thank you very much.
We will definitely, and if you give me just a second, I just want to say the fond memories I've got from visiting Manipal in the early 2000s, meeting up in Bangalore with Dr. Venkat, also colleagues we've worked with in Leicester, and visiting people there, and I was so impressed with your anatomy museum. I've still got pictures when I teach on anatomy and the live heart demonstration. I've got that heart with the red and the blue that you've got in your Dr. Pai's museum there. So Kasturba, thank you very much for inviting us, and Anita Shenoy and Dr. Manju Nath Babu. Thank you for that.
Thank you, sir.